Good afternoon, everyone. Thank you so much for joining our COVID-19 town hall today. We are joined by YKHC's President and CEO, Dan Winkleman, Dr. Ellen Hodges, YKHC's Chief of Staff, Jim Sweeney, YKHC's Vice President of Hospital Services, Dr. Bob Anders, the ANMC Administrator, and Dr. Michael Bernstein, the Providence, Alaska Chief Medical Officer. Good afternoon, everyone. Thank you for joining us here today. We are excited to provide an update to our region about the COVID-19 pandemic, as well as answer any questions that come in. For folks who are just joining us for the first time, please go ahead and drop any questions into the chat box. You can also use the Q&A function below to drop any questions that you have for our panelists today. Let's go ahead and get started with our President and CEO, Dan Winkleman.
Good afternoon. I want to thank all of our listeners and our panelists. Thank you for joining us. The purpose of today's virtual town hall is to get you, the listener, the most accurate and timely information on COVID-19 in the Yukon and Kuskokwim region. Also, I want to ask you for your help. It was recently reported by YKHC and the media that YKHC implemented crisis care standards. Basically, that is a series of policies that allows our providers to make decisions when we reach capacity with scarce resources. It was reported by local media that we had 5 COVID patients last week. What wasn't reported by the media was that weekend we had 24 patients, 6 of whom had COVID. We are a 26-bed hospital, so for YKHC, we were at capacity due to the nature of the COVID patients and their very high acuity. That high inpatient census was what necessitated YKHC to enact our crisis standards of care, which allowed us to increase our nursing ratios and offer more support for our providers if our census continued to increase beyond our bed capacity and they had to make difficult decisions. Fortunately, that did not happen. YKHC's implementation of crisis standards of care did not mean that YKHC was rationing care in any way. However, it could mean that if our inpatient census continues to increase beyond our capacity, or we stay at capacity for a long period of time, or our patient mix substantially increases with more COVID patients, and we continue to be unable to medevac to higher levels of care, or medevacs continue to be delayed. For the last several weeks, many hospitals across the state have had their inpatient census changing dramatically by the hour and by the day, and that's been true for us. For example, after that weekend, our inpatient census dropped to 21 with 6 COVID patients. Then we began encountering long waits for medevacs because there were no hospital beds at any facility with a higher level of care. The following day, our total census dropped again, but we still had 5 COVID patients, which was reported by local media. Yesterday, we were back up to 21 inpatients with 9 of those COVID patients. We have another surge plan for an additional 40 beds, but of course, we do not want to enact it. Compared to other hospitals that have run low on supplies, low on vaccine, low on monoclonal antibodies, low on oxygen, et cetera, that has not happened at YKHC yet. Instead, we are often in yellow status in different areas, but we have been managing effectively. And I'm very proud of my entire 1,400 employees for meeting this incredible challenge while still providing a high level of care for all of our patients. We expect these rapid fluctuations to continue while we still continue to see increasing COVID case counts, both here in the YK region and in South Central. This is why today we are asking for your help to relieve our capacity so our hospitals are no longer full. Clearly, we must and can do more. We need tribes and cities to encourage their citizens 12 and older to get their first shot of vaccine. Booster shots are also now available. Cities and tribes should consult their legal and financial advisors to look at ways to develop financial incentives for eligible individuals to get their first shots and become fully vaccinated. We also need to encourage everyone to follow CDC guidance and wear masks in indoor public areas. This is one of the quickest ways to take the strain off our hospital systems, both here in Bethel and in Anchorage and across the state. And we also need employers and schools, regardless of size, to demonstrate leadership and consider implementing their own vaccination programs. This pandemic will only end after immunity is achieved in high rates, and that can be done with a fully licensed, authorized, and safe vaccine like Pfizer's. With few exceptions, we have found that employers and schools that have followed multi-layered COVID protocols have been able to keep transmission low and stay open. To date, more than 6.38 billion, with a B, billion shots have been given in 184 countries across the world. Lastly, social distancing is also important. We have found that our friends and family are spreading it to each other. Temporarily wearing masks and not visiting other households, especially the unvaccinated, is key while rates remain at their highest levels we have ever seen. Unfortunately, Alaska is currently experiencing some of the highest rates in the United States and the world. Dr. Hodges and Mr. Sweeney will now give us an update on our current COVID rates here in the Yukon-Kuskokwim region and our strategies and what we're doing about it here. Thank you.
Good afternoon, everyone. My name is Dr. Ellen Hodges, and I'm the Chief of Staff at the Yukon-Kuskokwim Health Corporation. I've been privileged to serve this area for approximately 18 years. We currently have 355 active cases in our region. These are spread out in 32 different villages and Bethel, so 33 different affected communities, many of them with widespread based community transmission. More importantly, we have approximately 1,000 people who are in quarantine for being exposed to the virus and are unable to go about their daily work because of being exposed to the COVID virus. We also have a good news. We have some vaccination rates which are improving, although they're not exactly where I would like them to see. So we like to talk a bit about our vaccination rates in terms of the percentage of the total population that has been fully vaccinated. And that is right now at 56.8%. And then we talk a bit about our eligible population that is completely vaccinated. And that includes anyone who is age 12 and older who would be eligible for a vaccine. And that's at 74.4%. Our population in our region, as many of you know, is very young. It will be difficult to achieve a high number of total population vaccinated until we can vaccinate our children who are younger than the age of 12. And I will pass it off to Jim Sweeney to talk about some of our regional strategies for control of COVID.
Thanks, Ellen. Good afternoon, everybody. I'm Jim Sweeney. I'm the Vice President of the hospital. And some of the regional strategies early on in this, we produced a COVID response teams that we were able to deploy to the villages really quick when there was an issue that was arising. These consist of nurses, technicians, and providers who can get on the ground by charter, however we need to get them there quickly to respond to issues where we have outbreaks coming up. And we've continued that for the past really year and a half since this all started. Additional to that, we've set up testing and vaccination sites here in Bethel and in the villages. People are able to walk in and get their vaccinations here at the hospital, and with a little bit of advance notice, they can receive them at the village clinics and at the sub-regional clinics throughout our service area. Testing, we also have made available here in Bethel, and we have rolled that out to the villages too, where people can make appointments and go in and be tested at the clinics and at the sub-regional clinics. On a weekly basis, and sometimes on a daily basis, we're meeting to review our COVID strategies. We're looking at our supplies of vaccine, supplies of our PPE, our testing issues, and our abilities to test in-house, and our staffing. Additional to that, we look at where we're sending our teams each week to make sure that we're sending them out to the most appropriate place. And sometimes that changes. That might be one place on Monday, and by Wednesday, we've decided that we need to redeploy people somewhere else in which we meet, and we do put them into a different location depending on what's going on, where the testing is needed, and what type of outbreaks that we're having. We also meet with our health aides weekly to answer their questions and provide support to make sure that we're telling them and giving them everything they need that we can give them, and supporting them and backing them up, because they're on the front lines out in the villages, and we really need to be there for them. Every 2 weeks, we meet with our community partners in the school districts and answer questions, provide support. We do the same thing with them, basically go over what we're doing, what our current vaccination rates are, where we're seeing issues arise, We publish that on our website every day, and at the end of the week on Friday, we put a situation report up that shows the percentages throughout our region of where we're seeing outbreaks and where we've had issues or where things are beginning to die down. We also frequently participate in tribal council and city council meetings to answer questions and provide advice on mitigation strategies. And we meet quite a bit with individual tribes or individual cities to offer them advice. And with that, Ellen. On the monoclonal.
Oh, absolutely. So one of the things that we've been working very diligently on right now is being able to provide monoclonal antibody treatment to our patients in villages. So this has been available to our patients who live in Bethel since the monoclonal antibodies have been available on the market for emergency use as authorized by the FDA. However, it's always been challenging to provide these monoclonal antibodies to patients who reside in villages, because they have to be administered by a medical provider who is specifically trained to handle some of the adverse outcomes that can happen. And prior to recently, they had to be given IV. Recently, we were allowed to give them by subcutaneous injection. And so we have expanded our ability to access monoclonal antibodies. We reach out to individuals who are in our region who might benefit from this treatment. This is a treatment that provides, after a person has tested positive for COVID, provides them with some additional support in their immune system so they can fight off the infection a little bit better. These medications have to be used before a person requires hospitalization or oxygen, and it can prevent severe disease and hospitalization. So the method we go about that is identifying those who have tested positive and reach out to them and offer to fly to the village in order to administer that vaccine. As everyone knows, people who have tested positive cannot get on a commercial flight to fly into us in Bethel, and many of our patients who test positive are out in our villages. So we've been stepping up that program. It has been very successful. So if you are a person who has tested positive and you believe you meet the criteria for getting monoclonal antibodies, generally speaking, this is individuals who are greater than the age of 65 or younger people who have health conditions that might make a serious infection very dangerous. Those are the people that we would like to hear from. You can either, and I think Tiffany will be giving us numbers that we can call as we go on in this presentation, so that you can call and request us to review it, look at your record and see if you qualify for monoclonal antibodies, and we can reach out to you and make arrangements for that. It's something that we had, like I said before, we had been providing in Bethel on a regular basis, but now we believe we can safely provide this in the villages. So I want to make sure everyone understands that this is for people who are age 65 and older, or who are less than the age of 65 with a chronic health condition that may benefit from monoclonal antibodies. Thank you very much.
All right, thank you, Dan, Dr. Hodges, and Jim for that introduction. Let's take a moment to hear from our referring hospital partners. Let's begin with Dr. Anders. Dr. Anders, can you give us a quick update on the COVID-19 pandemic and the impacts that it's having on your particular hospital system?
Thank you, and thank you for the invitation to participate in that the panel. I appreciate it, and much of what I'd like to reinforce what Dan said related to mitigation measures. We're in the same position of strongly advocating for those in the Anchorage area as a hub for the regional patients who come into Anchorage. Those mitigation measures have been shown to decrease case counts rapidly, like Dan identified, limiting the social circles and the public indoor masking. Without those measures in place in Anchorage, I think all three hospitals in Anchorage, and I know Dr. Bernstein is on after me, we've been extremely challenged for the last 2 months with capacity related issues, and COVID has been driving that. As Dan noted, it does fluctuate frequently. So this morning, we're fortunate we only have 17 active COVID-19 inpatients at ANMC. We had been ranging in the mid to upper 30s. The number has decreased relatively rapidly over the last week, which has been very good. We still have post-infectious COVID patients. So we still have 10 patients who are still recovering from COVID, but they may be out of the infectious period here. The critical care space has been extremely challenged at all the hospitals across Alaska, and at ANMC in particular. We have been at 100% capacity, which makes it extremely challenging. And I know Dr. Hodges and I communicate frequently on this. Trying to find room for patients in Anchorage is extremely challenging, particularly for those with critical care. But this morning, again, which could change by afternoon, we had 3 open CCU beds. Part of that is related to the staffing support we've received. So we have not only, sometimes we may have open beds, but we don't have necessarily the staffing to staff them. But we received at ANMC through the state of Alaska contract a total of around 40 nurses as well as 10 CNAs. We also had a federal deployment of what they call a disaster medical assistance team out of Massachusetts to come here just based on our scenario and what's going on in Anchorage and at ANMC, which included another 35 personnel. And IHS also deployed 2 pharmacists here to help us. The staffing, despite some press components that speak otherwise, it has not been impacted by ANMC requiring the vaccine. We haven't seen any turnover related to that at all. The community spread of COVID significantly increases and challenges our staffing. The other day, we had 3 CCU nurses who couldn't come in because the daycare here on campus closed down because children were positive, or we have positive employees. So the community spread is a much bigger issue for us for staffing because that impacts us on a day-to-day basis. We, like YKHC, also last week implemented crisis standards of care. And much like what Dan said, it does provide a structure for us to make sure that we're allocating internal resources appropriately. We have not had to make any of the really hard decisions that come under crisis standards of care, but it helps us to get in a position, and I think both internally, so that if we are in a position, because we're really walking a fine line every day, it seems like, and trying to find capacity for patients, that if we have to make decisions on how best to allocate resources, we have that structure in place. And I also think it's important statewide, because it shouldn't just be within ANMC, it should be a statewide perspective that we account for patients who are in rural hospitals at the same time we're looking internally at the patients we're seeing here and at Providence as well, that we do this in a collaborative manner. We had been limiting same-day admission surgeries significantly. We were not scheduling any surgeries except those that were urgent or emergent that required hospitalization because we needed the bed capacity. We have this past week started to open that up a little bit. So at a minimum level, as day to day, it's looked at to see whether we can continue those cases or not. But that is something new that we were able to just with the decrease this week. But it does tend to fluctuate, and we're prepared to change that on a day-to-day basis. From ANMC's standpoint, our field clinics, we work really closely with YKHC. We will send our specialists out to field clinics as needed and as desired by YKHC, making sure that we're in a position where it's safe and appropriate to deliver that care there. But at times it makes a lot more sense for us, I think, to send a specialist out than to send lots of patients into Anchorage where it is a risk for that. So we are continuing those operations. And that's all I have for a summary. Thank you.
Thank you so much, Dr. Anders. Dr. Bernstein, let's turn over to you if you can maybe give us a couple thoughts on the impacts of the pandemic for your hospital system, and particularly when you're partnering with organizations like smaller hospitals like ours.
Sure, and thank you for the opportunity to participate in the panel. My comments will sound very similar to Dr. Anders. We also recognize that for the past 6 weeks or so, we've had a very limited ability to assist with taking patients from smaller hospitals and even villages, and those have been very difficult decisions that we've had to make, basically because our intensive care unit beds were completely full, and we've instituted a number of mitigation strategies such as limiting various types of elective surgeries to help with that flow. And even last week, we moved for the first time in the pandemic to our fourth surge planning level and placed temporary negative pressure ventilation into some rooms that were converted to provide intensive care that we had never done previously in the pandemic. But this week, we do have some signs of optimism, similar to what Dr. Anders said. Our total census and COVID census appears to be plateauing. Obviously, it can change day to day or week to week, so we're being cautious in that interpretation. But in addition, we have had with the state contract for outside healthcare workers, we've had 43 since last week that have been able to join us, including 31 nurses and 5 respiratory therapists. The respiratory therapists were desperately needed and have really helped. And so we actually anticipate that this week we may be able to take a small number of transfers in, and certainly we'll work to take the most critically ill that could benefit from being in Anchorage with the resources that we have here. Our transfer center also in the last several weeks has been trying to assist when we can't take a patient from an outlying area. They've also been working with other partners in the state to try to help patients find a location to be transferred to as well. I saw a question in the chat that I might just comment. Someone asked about when the EUA for vaccination of 5 to 12-year-olds might be available. And the word we have is that that Pfizer has not submitted those data yet, but they are going to do very soon. And the FDA has actually scheduled a review meeting on October 26th, anticipating that the results of that trial in 5 to 11-year-olds will be submitted. So there is the possibility that the Pfizer vaccine could be available for children in the 5 to 11 year range by the end of this month. And I just want to thank Dan Winkleman for his message to all of us, and just want to support that vaccination is the real key to bringing the pandemic under control. But with an agent like Delta variant that we know can have very high transmissibility, that the social public health measures that we use, as Dan and Dr. Anders mentioned, of masking indoors and limiting our bubbles and social distancing remain critical during this level of community transmission. So thank you.
Great. Thank you all again so much for being here. We're going to pivot to taking some question and answer. And we also want to acknowledge that this event was supposed to be live streamed on YKHC's Facebook page. We seem to be running into some error issues, and it might be associated with the outage that the platform experienced yesterday. So our apologies. This recording will be shared on our website as well as social media. Let's begin by talking about vaccine boosters, and maybe we'll start with Dr. Hodges, and we'll ask Dr. Anders and Dr. Bernstein to also contribute where you feel necessary. Dr. Hodges, YKHC announced vaccine boosters are available for people who had received a Pfizer, or what's also now known as the Comirnaty COVID-19 vaccine. Does YKHC encourage all eligible individuals to receive a booster? And can you explain about why and what does that offer, and how long does it take to be effective?
Absolutely. We do recommend boosters for everyone who is eligible. So for our population, this is anyone who received a primary series of Pfizer. So their first and second dose was Pfizer, and it has been more than 6 months since that second dose was given. Because Alaska Natives have such a high rate of death and hospitalization associated with COVID-19, we encourage all Alaska Natives to receive this vaccine booster shot. Also, anyone aged 65 and older, and those who are between the ages of 18 and 64 who have underlying health conditions that might make a serious infection with COVID be a really big problem for them. And lastly, we recommend it in anyone who's in a high-risk occupation with lots of interaction with the public to go ahead and get that booster shot. So this would include healthcare workers, first responders, people who work in grocery stores, law enforcement, that kind of those kinds of individuals, our clergy, those kinds of people who have lots of interactions with the public and a high risk for a transmission of the vaccine. So generally, we think about 2 weeks after that dose, your vaccine antibody levels should be fairly high again, but I can't emphasize enough, it's still absolutely critical that we all wear masks, especially when we're indoors in public spaces or with people who are outside of our family unit to interrupt the transmission of this virus. So again, for everyone listening, we strongly encourage you to get a vaccine booster if you fit in that category. We don't know yet when Moderna boosters or Pfizer or Johnson & Johnson boosters might be available. As soon as we know that information, we will be reaching out to everyone for that as well.
And Dr. Hodges, can you also talk about any potential side effects from the booster if somebody is pregnant, can they get a booster dose of Pfizer?
Certainly. So the side effects for the booster appear to be about the same as for people who got the first and second doses. So we're hearing about a lot of sore arms, some body aches and joint aches and headaches, generally very self-limited, responds well to Tylenol or ibuprofen in a little bit of time. And the CDC and ACOG recently recommended that all pregnant and breastfeeding women who are eligible for booster go ahead and receive a booster. So that's again, people who received the primary series of Pfizer and they're 6 months or more from that second dose. If you're pregnant and breastfeeding, we'd like you to get that booster shot. And also just strongly encourage pregnant women to get that first dose if you haven't yet got vaccinated. Pregnant women have a 2 to 3 times higher rate of death and hospitalization from COVID alone. And I think it's really important to recognize that can lead to death, it can lead to preterm birth, it can lead to stillbirth. And these are all things we really strongly wish to avoid. So vaccination of our pregnant moms and our breastfeeding moms, we think is so important. Reach out to your healthcare provider, schedule an appointment and get that first dose of vaccine to get that scheduled. We also think that it's possible that the antibodies that you get when you make antibodies can be passed on to the baby because newborns aren't eligible for vaccine yet and probably won't be. But that's one way to protect the baby from a COVID infection. I saw on the news that there was a 2-week-old that had been hospitalized somewhere in our state, which is just devastating. So what's one way to protect your baby is for the mom to get vaccinated. You can also passively pass antibodies when you're breastfeeding. So if a breastfeeding mom is vaccinated, the antibodies can pass through the breast milk and protect that baby. So just really strongly encourage our pregnant and breastfeeding moms to go ahead and get vaccinated.
And then a final question at this time for boosters. Can you answer, do people who just had COVID and potentially people who have had a breakthrough infection of COVID, should they also get a booster?
Yeah, we're strongly encouraging everyone to get a booster, whether or not they have been recently infected with COVID or have had a breakthrough case of COVID or an infection of COVID after having received both doses of their vaccine. So just go ahead and schedule a booster if you're in that category. The most highly protected individuals are those who have had their primary series of vaccine and a COVID infection, but we'd really like to avoid COVID infection in everyone. We know there's long-term effects from COVID, and we just would like to avoid that in any of our patients. So go ahead and get signed up for a booster.
Great. Yep, go ahead.
Can I interject? I'd just like to ask the doctors if you could explain why Delta is so much more transmissible, and let the viewers know that this really is a different variant than what we saw last year. And I know there's lots of villages that escaped the wrath of COVID last year, but are now experiencing it for the first time. And They don't really understand why, but it really boils down to transmissibility. Instead of infecting 2 to 3, now it's infecting 8 or 9 on average. If you could explain that.
Dr. Hodges, I'm happy to take that. So just like Dan Winkleman said, the transmissibility is significantly higher compared to the first waves of virus that we saw, whereas a typical person before would infect a couple other people. This virus is so transmissible that it allows an individual to infect 6 to 9. And the exact reasons why it's more transmissible, I think, are still being uncovered. But what we do know is that the levels of virus in infected individuals is about 1,000 times greater. And so there's something about the virus that it is able to reproduce in the human body more efficiently by about 1,000 times. And because of those higher levels of virus in individuals, that's at least part of the reason why you probably have to spend less time around somebody in order to be exposed to amount of their breath or their company to actually be infected yourself.
Maybe I'll add one thing that, in April, one of the best news that we heard related to the alpha virus was that asymptomatic people who were vaccinated really didn't carry the virus nasally. But what we've seen with Delta is asymptomatic people, even if you're vaccinated, still carry the virus and can pass the virus on. So Delta, to me, that's a completely different characterization. So even if you're asymptomatic and you're around other vaccinated people, you should be wearing a mask because you may be transmitting it to someone else. And that's a significant change from the alpha virus. So this Delta virus, even if you're vaccinated, asymptomatic, you may be at risk for passing it on to someone else, and why masking is so much more critical. Not only, like Dr. Bernstein noted, way higher viral counts, but also in the asymptomatic but vaccinated people that are at risk for transmitting it. So it's really important to have those mitigation measures in place.
I think that's a perfect segue, Dr. Anders, to a question that we have here. Why should I get vaccinated if I can still get COVID and potentially spread it? And there's another question here. Why do I still have to wear a mask even though I might be fully vaccinated? And what is the best type of mask to wear, particularly considering the Delta variant?
I could start and others could add as appropriate. The vaccination, what we have seen with Delta is it's still incredibly beneficial for preventing significant illness. So ending up in the hospital, ending up having long-term COVID, having the need for critical care, and even dying. The vaccinations are incredibly beneficial for those. So even with the possibility of breakthrough cases or asymptomatically carrying the virus, the benefits far outweigh not getting vaccinated related to that. And that's partly the reason, outside of I think there are some important social circles that you need to maintain with family and friends and need to have some communication without a mask. But I think at this point, that's why masking is important, even if you're vaccinated. And personally, I went through a period after the alpha virus, vaccinated people and being unmasked around them felt pretty safe. It doesn't feel safe now with the Delta virus, and I think that's a significant change. And until we get the community case counts down to really low level, and we know it's not widely circulating, I think we need to have the masking measures in place. And I don't know if one of the other physicians want to comment on the types of masks.
I think there's been some interesting information coming out about this recently about the type of mask. And I think the surgical mask, I'm wearing a surgical mask right now, might be pretty safe if it's nice and tightly fitted, and a triple layer cloth mask might be safe. There are also on the market commercially available KN95 masks and N95 masks that were available only to healthcare providers at the beginning of the pandemic, which also really protect their wearer well. I think it's important to remember that the primary purpose of masks is to prevent you from spreading COVID. So it works only if everyone masks. And that's an important thing that everyone needs to remember, is my mask protects you and your mask protects me. I think sometimes you see people with bandanas or gaiters on. I think those are probably not as good at protecting all of us from transmission, especially as Dr. Bernstein pointed out, there is 1,000 times higher viral counts in people with Delta variant infection, and that is the predominant variant. Almost 100% of the samples that are tested in the state are the Delta variant now. So that's just an important thing to keep in mind. And if you're going to wear a surgical mask, a cloth mask over it, a triple layer cloth mask over it may be useful, especially if you're traveling or in areas where there might be lots of unmasked people.
Great, and just to do a little commercial plug here, go ahead and drop any questions into the Q&A or chat box, and we're happy to ask those of our panelists. For folks who have questions about the monoclonal antibodies that Dr. Hodges referred to earlier, any questions about an initial series of vaccination, or any questions related to boosters, please call YKHC's COVID-19 hotline at 907-543-6949. There's a lot of curiosity in. Yep, go ahead, Dan.
Before we get to the rest of the questions, I know there's lots of questions about the schools and elementary age children who are not yet eligible for the vaccine. Maybe now's a good time if we could listen from our physician staff here on why we need to keep our schools open, and some recent studies that have supported that, even though our rates are very high here in the Delta.
Yeah, this is Dr. Hodges. I'll go ahead and start on that. So we have found in our contact tracing and case investigation that very few cases are actually associated with in-school transmission. Our schools are doing a fantastic job of mitigation strategies, mask wearing, physically distancing the students, and regularly testing them. Many of the students are catching COVID in the community. And studies have shown that when you take students out of school, it has the opposite effect. They are exposed to more virus in the community, and they are more likely to get COVID. So keeping our kids in school, where about 3% of our cases in our kids, so about a third of our cases are in children less than the age of 12 who cannot be vaccinated. So I think keeping those kids in school keeps them masked up, and it keeps them physically distanced and safe during that time period. And I think that's really important to keep in mind. There's also have been multiple published studies that have shown that you can safely do this with high background cases, as long as all those strategies are in place. It's very important that the students keep their masks on, that they continuously wear them properly. I have a friend who teaches preschool, and I think it's kind of an ongoing daily battle to keep those kids in their masks properly, but it can be done. And also making sure that you're socially distancing or physically distancing the kids from each other. And then, of course, regular testing. And then that way, I think we can really keep our kids safe and actually reduce transmission among kids while they're in school.
And just I'll add one comment that I saw in the comment section, GA schools, for all the teachers who have another duty now in ensuring that their students are wearing their masks appropriately all day long. I think that strongly appreciate the teachers that are doing that. But to me, when people say that masking doesn't work on the national level in schools, when everyone's wearing a mask, and I would bet the teachers reinforce that they're wearing them appropriately and doing it, the case counts are low. I mean, the protection is there. So it's a good example with kids wearing masks appropriately. Adults sometimes are more challenging to comply with those rules, but really appreciate the teachers doing that, because it can be done safely, like it's proving out to be.
Absolutely. And so a third of our cases are in students, but we think only about 3% of that is related to in-school transmission, and the rest is community-based transmission. So just emphasizing our schools are really safe. And I'm so grateful for all of our school partners and all the hard work. My dad was a teacher. I love teachers, and I can't believe how amazing they've been throughout all of this and in keeping our students safe.
Thank you so much for that update. Another related question, as with children returning to in-person learning? Should children be participating in sports?
So this is a great question and kind of thorny. So we believe it can be safely done with masks. A good example is our cross-country teams have done very well with masks. The students even practice wearing masks and running and keeping their masks on. There are some sports like wrestling where it might be very difficult to stay safely masked while you're wrestling. In those scenarios, we would recommend that be limited to vaccinated students only, and that masks be worn to whatever extent they can possibly be worn. And for travel, I know that one of our school districts has limited travel teams to those students who have been fully vaccinated, and we believe that to be a fairly safe strategy, as well as regular testing, especially after travel. I noticed there were a couple of questions in the chat box about testing after travel, something we strongly recommend. And we'd recommend you test about 7 days after travel. And that could apply to those kids traveling in school. But I think the more we normalize mask wearing, especially for our kids who cannot be vaccinated, I think the better off we're all going to be. And I think it can be safely done in that scenario.
I see that there's a lot of interest in the comments and some questions that have come in the chat box related to pediatric vaccination against COVID-19. So a couple of questions for our physician panelists. How can somebody protect their children who cannot yet get vaccinated? Can you talk a bit about the current impacts of COVID on children, rates of infection or hospitalization, maybe what we're seeing in some of our larger hospital systems? And can you give us an update on what you know as it's related to the development and approval and then potential distribution of COVID-19 vaccines for children under the age of 12?
This is Michael Bernstein. I can start that. So I think I mentioned earlier as well that we're anticipating that Pfizer will be submitting the data from their study of children aged 5 to 11 very soon, perhaps this week. And anticipating that, the FDA does have a review panel meeting already scheduled for October 26th. And so we're very hopeful that with the Pfizer vaccine that we could possibly have an emergency use authorization for children aged 5 to 11 for the Pfizer vaccine even by the end of this month. Of course, that is entirely dependent on the findings of the study, but preliminary word is that it's just as safe in children aged 5 to 11 as we have seen in the 12 year older and adult. For children who are not yet vaccinated, we have seen more admissions to the hospital than we did with earlier variants of the virus. I think Dr. Hodges mentioned that there was a 2-week-old admitted in Alaska recently, and we've seen other young children in higher numbers. And unfortunately, they can become very ill. So it is important to protect children. I think, as Dr. Hodges mentioned, being back in school turns out is probably a safer environment than for many of them when they weren't. And it's really the same mitigation strategies that we have been talking about, particularly why we have this high level of community transmission, to wear masks for any indoor activities outside of your own home, avoiding large gatherings, social distancing, really the same things apply. Thank you.
And I can talk a little, I'm sorry, go ahead, Dr. Anders.
Oh, go. I was just going to comment on the time frame, which is typical what we see with other drug development or vaccine development, generally pediatric patients are studied later after a safety profile has been established in adults for a prolonged period of time. Same with the strong recommendation for pregnancy that's come out. Generally don't do studies in a lot of studies in pregnant women, but we can evaluate the data over time to see how successful it is. And that, I think that's why some of the strength of those recommendations for vaccinations for pregnant women, as well as moving into the pediatric population, it's just a normal time frame because they do want to show a safety profile that is very strong in adults prior to moving into those populations.
Agreed. And just one last word on the distribution of COVID vaccine. When we get to the point where hopefully we can offer vaccine to the 5 and 11-year-olds, we'll be partnering with our schools to do in-school vaccination clinics whenever possible. The flu vaccine is also out and being distributed. So we're hoping to also increase the amount of flu vaccine that we've been giving out. It's certainly available right now. We are offering it here in Bethel in our wellness center, the same place where people have been getting their COVID vaccines. You can get them on the same day, get them in different arms in case you have a bad reaction. So we know which arm was the one that was sore from the COVID vaccine versus the flu vaccine. And same for our kids. So we will be offering those in-school vaccination clinics. We have done this in the past with flu vaccines as well. So we'll be reaching out to our school partners to get that set up to make sure we have written permission from every parent who wishes to have their child vaccinated, so that we can assist to the greatest extent possible in getting that age group vaccinated. And we think that's be a very important tool in reducing overall transmission as well as protecting our kids in that age group.
And that's a great segue, Dr. Hodges. Can you talk about what has taken, why it has taken some time to get a children's vaccine approved, what that might look like, and how people can protect children who are not old enough to be vaccinated yet?
Sure, and Dr. Anders hit a bit on this. We really need to make sure that the vaccine, especially for our kids, is safe. So there has to be quite a bit of safety data collected in our adult patients. And they also have to work out the dose. It will not be the same dose in all likelihood as the adults. So we make sure that we have the minimum effective dose, meaning that we're not giving them too much vaccine and giving them just the right amount of vaccine to promote an antibody response. That's another reason why it takes longer for the kids, and a great deal more scrutiny, I think, it's placed on these vaccines to ensure their safety for that. And I think to protect our kids, every eligible person in our region needs to be vaccinated. So if you are age 12 and older, you are the parent of a 12 to 18-year-old, let's go on ahead and get that first dose in the arm. That's probably the #1 protection that we can do. Second, wear a mask at all times when you're not in your household. Making sure that you wear it properly, covering both the mouth and the nose. And we talked a bit about appropriate masks before, but just making sure you're wearing that mask everywhere you go. We don't think it's necessary in the out of doors if you're separated by more than 6 feet from the people around you. So I know I like to exercise out of doors. So when I go for my morning run, I don't usually wear a mask, although I bring a mask with me in case I encounter someone. So I think those are some really good strategies. And avoiding large gatherings. I think Dr. Bernstein mentioned that. This is not the time to be attending large gatherings. We really need to keep our distance from each other, 6 feet or more at all times if possible. And those are kind of the ways we can keep our kids protected. But again, everyone who is eligible for vaccination, I'd like to see, I think we're at 74.4%. I said earlier, I really want that number to be 100%. 100% of those age 12 and older. That's what's going to keep our kids the safest until we can vaccinate everyone.
So Dr. Hodges and Dr. Anders and Dr. Bernstein, I think you've all mentioned that it's flu vaccine season. Should people get a flu vaccine? If so, is there a wait time between an initial series of COVID-19 vaccine and flu vaccine, or boosters and flu vaccine?
I can start that one. So when we first began giving COVID vaccines, we did want them separated from other vaccines, but we've learned now that 6 billion doses have been administered worldwide, that these vaccines can be administered at the same time as other vaccinations. Dr. Hodges mentioned it is important to be sure which site was given for which vaccine, because on the very, very small chance that someone doesn't tolerate a vaccine well, we want to know which one it was. But yes, you can get the flu vaccine and a COVID booster vaccine on the same day. And we really encourage people to get the flu vaccine this year. Last year, we had almost no flu season because everybody was wearing masks and social distancing. And while we don't know for sure, but there have been times in the past where following such an absence of a flu season, the following season can have something of a rebound, and it wouldn't be good to get a bad flu or a bad flu and COVID together. So we really encourage people to get their flu vaccine. Thanks.
I was just going to say that we are offering the flu vaccine out in our villages at the same time as you get your COVID vaccination. That's really important. That's also available here in Bethel, as Dr. Hodges said. I believe most of our villages have received the flu vaccine. We do have some that have not received it yet. We're working with the airlines right now and doing that. And we are also aware that many villages are not receiving providers timely right now. And the reason for that is because we're seeing so many COVID outbreaks in outlying villages that we put COVID teams together, and they're often traveling out and helping us respond to these COVID outbreaks. So for those of you that are in villages, please be patient, continue to be patient and waiting to see our providers. We will be coming to see you, but it is taking longer now because we have so many outbreaks occurring out in our villages, and we're responding to those in a timely fashion. And that is the current priority right now.
Yeah, and I think the last thing is I'll make a little advertisement plug here. On October 23rd, we're planning on a mass vaccination clinic in Bethel and as many of the villages as we can pull it off in. So mark that on your calendar if you want your flu shot. October 23rd, we'll be offering flu shots. We'll probably do it in the parking lot across the street from our main hospital like we did last year, and at the Saturday market, if the Saturday market is held that day. And then as many villages as we can. We will also offer COVID vaccine at the same time and COVID testing. So you can sort of have a one-stop shopping as it were. So October 23rd.
One other piece of good news, and Jim Sweeney can speak to this more, is that we did receive about 10 nurses yesterday and some more nurses today, I believe. And that's going to greatly help our providers to get back to traveling and doing the primary care that needs to be done out in all of our villages. So that will help, but we just received those today, yesterday and today, I believe, right, Jim?
Yes, we got 10 folks in yesterday. We got 10 nurses and 1 CNA in, and we're getting 3 more nurses in tomorrow. They're going through our orientation right now, and they'll be rolling out, and that's going to take some of the stress off the other departments that we've been seeing. So that's very welcome. That's from the program that the state set up that Dr. Anders was talking about earlier, that they got some nurses from it too. So yes, they're here, and we're very grateful.
All right, in the last few moments that we have today, it looks like there's a theme of questions as it relates to testing. And so we want to touch on some testing questions before we end our time today. Before we jump into that question, I just want to encourage the public, if you have questions, if you live in a village and you have questions about availability for testing or COVID-19 vaccinations, please call YKHC's COVID-19 hotline at 907-543-6949. As Dr. Hodges mentioned earlier, that's also a great place to reach out to if you have questions about monoclonal antibody treatment. Again, that number is 907-543-6949. So in the last few minutes, I would ask our panelists to speak about the importance of testing. How should I know if I get a test? Sometimes I have seasonal allergies. Maybe my nose is running this time of year. Also following travel, maybe I'm fully vaccinated, but I've traveled out of the region or out of the state. Can you touch on when people should be testing? Should they be testing upon return from travel or within a certain time period for travel? So testing, whether vaccinated or unvaccinated.
Sure. This is Dr. Hodges. I'll go ahead and start on that. So we generally, for travel, I'll touch on that first. We would recommend that anyone test, even if they're fully vaccinated, that they test about a week after travel, about 7 days. And I think that's important because travel itself can be a bit of a risk factor. And then maybe during your travel, you could been exposed to others who maybe were less cautious about mask wearing than we are in our region. So about a week after travel, that applies to vaccinated and unvaccinated individuals. And then just to be cautious for about 14 days after you travel. So during that time period, really making sure that you're very vigilant about your masking. And then if you develop any symptoms in that time period, to immediately go get testing. And we get asked that question about seasonal allergies a lot. My nose is always runny. How will I know if this is COVID or not? And I think getting tested is never wrong. So if you feel as though something has changed about it, go ahead and get tested. And if you feel sick at any time, certainly if you ever have a fever or a cough that accompany that, that's very uncommon with seasonal allergies. But it's never wrong to try to go get a test. And I think that's the message we'd like people to have. If you feel ill, make sure you get a mask on. Even in your own home, get a mask on and go get tested as soon as you can. But I think we often get that question about seasonal allergies, and I don't know if Dr. Anders or Dr. Bernstein have anything to add to that.
No, I agree with your statement. It's never wrong to get tested. If you're thinking about it, that's probably a good idea. If something's changed from what's normal with you, probably a good idea for your safety and the safety of others around you. I think testing has been shown to be a really good measure in place to help prevent this further spread of COVID. So.
And then maybe just thank you all so much again for your time this afternoon. And in a final question, I know that there's some interest in understanding where we are in the epidemiological curve of current cases. Are there any projections that indicate we might be peaking in this current surge? And if not, what are the prevention measures? And then after you guys have finished that answering that question, I would ask Dan to conclude us for this afternoon.
Well, I think I'll defer this one to Dr. Bernstein and Dr. Anders. I think maybe they're seeing a little bit of a break in Anchorage. We have not yet seen that out here. Our cases are still at about the same rate. We had one of our highest case totals of the pandemic just a few days ago. So I would like to see this pandemic on the downside, but I'm interested in what they have to say about what they're seeing in Anchorage.
Yeah, thank you. Alaska is big. We're as big as Europe, so we will have different geographic responses. The Delta agent may have arrived in certain areas later, and it will run its course. So I think as a statewide, it looks as though we are seeing a plateau. We've reached a peak, but in any individual geography, borough, village, they could still be on the upslope. And overall, community transmission is still higher than it was even last winter during the previous highest surge. So all the reason to do everything we were talking about, still get vaccinated if you're not, use masks, don't have large gatherings. Thank you.
No, just to add, when you look at the community transmission rates, from a hospital, you just know a certain percentage of those people are going to end up in the hospital, a certain percentage will end up in the CCU, and we're still having phenomenally high case counts, even compared globally. Alaska's having phenomenally high case counts. So today it looks pretty good at ANMC from patient levels. I'm still worried at where we're at with the number of community cases out there, that it's still going to be a challenge for a while.
I'd just like to say thank you to all of our panelists for your participation. This is very important for the public, that we give them the most accurate information and timely information on COVID that we can. This has been about our 10th virtual town hall that we've had in the last 21 months. We've done the most outreach and community education in the company's history, and we can be found on Facebook and our YKHC.org, or if you take your smartphone, for those of you that are listening, you type in YKHC COVID, you'll find more information than you can imagine. I just did it a few minutes ago. Unbelievable. The other websites to go to are the CDC in the state of Alaska, and of course your individual health provider. So thank you again very much, and have a good afternoon.